Welcome back to Neurology 101 on the ProPA podcast. I'm Dr. G, and today we're continuing our Other Encephalopathies mini-series with a condition every PA needs to recognize, hepatic encephalopathy. It's reversible, but if missed, can progress to coma or even death. Let's break it down. Did you know that hepatic encephalopathy infects up to 50% of patients with cirrhosis, and it's often the first sign that their liver disease is decompensating? Recognizing the early mental status changes could be the difference between recovery and ICU level care. Let's look at the kinder patho. What is hepatic encephalopathy? Well, hepatic encephalopathy, or HE, is brain dysfunction caused by liver failure. The liver normally filters toxins, especially ammonia, from the blood. When the liver function fails, toxins build up, cross the blood brain barrier, and disrupt neurotransmission. This results in an altered mental status, ranging from subtle personality changes to confusion, Asterixis, and coma. Triggers: GI bleeding, infection, electrolyte abnormalities, constipation, sedatives, high protein intake, and noncompliance with lactulose. So, how do these patients typically present? Well, symptoms can range from mild to severe, and it can include personality changes, irritability or confusion, an asterixis, or what we like to term a liver flap, disorientation, somnolence or stupor, and coma in advanced stages. Consider using the West Haven criteria, grades 1 through 4, to stage severity. Patients often have underlying cirrhosis, ascites, or jaundice. All right, how do we diagnose these patients? Well, it's a clinical diagnosis. There is no single definitive test. We might see an elevated ammonia level, but it does not always confirm our diagnosis. We want to check for precipitating causes like a recent infection or a bleed. Labs, we want to get LFTs, an ammonia level, a CBC, electrolytes, and renal function. And we want to get an INR, which shows us liver synthetic function, and an albumin. An abdominal ultrasound with Doppler may help assess liver flow. We also want to rule out other causes of altered mental status, including hypoglycemia, infections, drugs, and stroke. Treatment? Well, we want to identify and treat the trigger. If we have a GI bleed, we want to do an endoscopy. If we have an infection, we want to initiate antibiotics. And also, we want to correct electrolytes and stop sedatives. We need to try to lower the ammonia. We can do this by giving the patient lactulose, which is a non-absorbable disaccharide which acidifies the gut and traps ammonia. The goal is to be 2 to 3 soft bowel movements per day. We can also give rifaximin, which is a non-absorbable antibiotic that reduces ammonia-producing gut flora. We can add for recurrent HE or if unresponsive to lactulose alone. We also want to encourage supportive care. We want to monitor the airway in grades 3 and 4, and we want to avoid protein restriction unless absolutely necessary. Now let's look at the book med versus the street med. Book med, we'll have a confused cirrhotic with an elevated ammonia, we'll start lactulose and look for infection. Street med, a 58-year-old with hepatitis C cirrhosis comes in confused, disoriented, and flapping his hands. His wife says he hasn't pooped in 4 days and skipped his lactulose. You treat the constipation and the hepatic encephalopathy together and avoid intubation. Some quick clinical pearls. Asterixis equals metabolic encephalopathy clue, especially hepatic or uremic. Ammonia can be falsely normal. Treat based on the clinical picture. Lactulose noncompliance is a common cause of recurrence. And recurrent hepatic encephalopathy, it has a bad prognostic sign. We want to start rifaximin early. HE may be the first sign of liver decompensation. All right, now let's do some practice PANCE questions. A 62-year-old man with cirrhosis presents with confusion and Asterixis. His ammonia is elevated. What is the best initial treatment? Is it A, protein restriction, B, lactulose, C, IV glucose, or D, haloperidol? If you said B, lactulose, you are correct. Lactulose traps ammonia in the colon and is the first-line treatment for hepatic encephalopathy. A patient with known cirrhosis presents with altered mental status. He has been noncompliant with lactulose. What lab finding would best support hepatic encephalopathy as the cause? A, an elevated INR, B, an elevated serum ammonia, C, elevated ALT, or D, low albumin. If you said B, elevated serum ammonia, you are correct. This is a supportive finding, although not definitive. Diagnosis is still clinical. Okay, so some final thoughts. Hepatic encephalopathy is reversible, but only if you think of it. Know the triggers, recognize the early signs, and treat aggressively to protect the brain from the body's own toxins. Next up in our other encephalopathy series, we have hypoxic ischemic encephalopathy, brain damage after loss of oxygen. If this episode helped you feel more confident with liver-related altered mental status, forward it to your internal medicine study group. And remember, this is the Pro PA podcast, where future pros in medicine are made. See you in the next one.